Bueno, pues le damos paso a...
We now give the floor to Marina Berenguer for the first presentation of the day. Very good morning. Good morning, everyone. It is a pleasure, really, to be here. I've been coming to these gatherings. You've seen my face because from Madrid, Burgos, and now Valencia, we have been meeting each other for many, many years, and it's always a pleasure to be here and to presenting to you what we are learning. We are learning along the way with you, and today I will be talking about screening failures or mistakes that we all made, and some are not even clear. They're aspects that have come from abroad, and this is based on the analysis that we have made. This is just to give you an idea of what we have when we have an intake of copper. Copper is in a multiplicity of foods. Copper is ligated. It cannot just go by itself. So albumin, protein, is the carrier and takes it to the liver. And TPCB7 enzyme is the one that will make the clearance or the washout, because the human body is very intelligent and says, I just take what I need and the rest is a washout and goes away. So it eliminates that, it clears that, and that bonds to a quote-unquote taxi that takes it along the highways. That is the blood torrent. It takes it to the brain, to the kidneys, anywhere we need it, which is very important for brain function. In patients that are presented with Wilson's disease, what we see is that this enzyme does not work, and we are unable to eliminate this, and we cannot link it to that taxi, to the ceruloplasmin, and it starts to have a lot of copper in the liver, and a little bit it is excreted freely into the bloodstream, and that becomes toxic. I know I am saying this in a very plain words and not scientific words, but it allows us all to understand the techniques that we will see later. Why do we have diagnosis issues? This ceruloplasmin is low. It cannot be created, so we're going to have figures that are quite low. Also, the free copper, because it should be on board that taxi, we see that free liver is there, but unfortunately we don't have techniques that can be used in all medical centers or hospitals or care centers. That free copper is going to be cleared through the kidneys. Human beings, we eliminate via liver, through feces, or through the kidneys. That's the filters that we have. Excuse me, let me go back. And the copper that we have in urine is high. We shouldn't have these levels of urine copper. And total copper, and I have explained this year, and I always use this as my first slide for the families. I show it to the patients, I show it to the nursing staff that I work with. Free copper is the copper that is, it's a ligand of, it's bonded to the taxi plus all the copper that we have, but most of the copper, that total copper that is measured in the battery of tests in the lab, is the one that is linked to the ceruloplasmin. And what our machine measures is, so despite we have this free copper, no, this is hard. No, seriously. Okay. So it's not that I am dyslexic with the PowerPoint going up and down, but anyway, when we do biopsy, then we would see, or it should be high. We have so much copper that it goes straight into the bloodstream. So what we have here is a set of tests, and you say it should be easy because definitely one that has this results, even though those people that are presented with liver dysfunction, they just have transaminase elevated levels. But when you have ceruloplasmin, high kappa, well, pretty much what we have here, we have the diagnosis. If you do a biopsy and you see levels that are over 250, it seems that the diagnosis would be quite simple. But if we have copper, that was very easy to see. Well, it's not that easy to see because we also have diagnosis, false positives. But anyway, but I could say, I have a diagnosis that should be quite clear. That's not true. But I will talk about the genetics later. But why isn't that? And why do we still have issues with the screening, with the diagnosis? Because in medicine, nothing is black, nothing is white. Everything is, unfortunately, is still too gray. So what do we do? Under 20, ceruloplasmin could be normal in hepatic manifestations, especially in the initial stages. And sometimes you could have that. And it increases, and this could provide, and it could be normal. It could be a woman that is pregnant, and it could be low in some of them. You have celiac patients or hepatic insufficiencies, or it could be low in those heterozygous one little stick, I'm quoting the speaker, one little stick is positive, the other one is not. To be honest, if we use the threshold or the cutting value, which is 12 milligrams DL, then we will be testing positive individuals, but Wilson disease, WD, would be confirmed in a very low percentage, 55%. So maybe 40% of this ceruloplasmin could be. But if we bring the threshold down to 10, that will be a very, very little concentration of ceruloplasmin, and then that will be corresponded to a WD. In urine, we pretty much have the same issue. So normally we have a lot of copper that is being cleared via urine and not feces, but we also have false positives and false negatives. And it's pretty much similar to what we have. The thresholds, it could be 40 micrograms, 24 hours, and there we could have people that could be quote-unquote relatively, but the specificity, but for that patient to really be presented with WD is only 87%. If we move the threshold to 100 micrograms, 24 hours in the clearance, if we find it, it will have more probability that that patient is really presented with a WD. And something that we have been told in college, etc., copper in liver was the gold standard. If you had over 250 micrograms in the biopsy, oh my goodness, that was Wilson's disease, and you will see cases. That's what my professor said. And now you see that that's not the case. The causes, we can discuss that later. What is important is that copper is distributed in a patched fashion, and therefore concentrations are going to be, there's going to be a lot of scarring. So when you did the biopsy, you could find patients that have a lower between 100 and 200, but be positive for WD. And then we will talk about genetic studies. It depends where you are located. And you can do Carmen. Carmen is like she keeps on doing it and doing it and doing it. And then you could have the result to levels that are 99+%. But that's not always the case. You don't always have Carmen, but just like in medicine, where we have no specific test that is 100% reliable, our diagnosis and screening is presented with everything that I have told you. The ring, KF rings, copper in urine, urinary copper, liver copper. So some experts decided that with the C is above 4, then it will be WD. We're going to talk about 2 novel issues here. I'm going to share with you some cases. One case is the exchangeable copper in the blood. Again, we have almost everything that is part of that taxi. Let's call it taxi. And that's very little. Patients with WD, we have very little ceruloplasmin, so it's going to be very low. And what we're going to have is a lot of free, this radical copper. If we divide this by the total in WD, we see a lot of free copper. And we have seen in patients that they have that exchangeable copper ratio, that REC. We're talking about 14 to 18 and above. Then these are studies that have been, and essays from Zoe Mariño's lab. They have reviewed their cases. And yes, it seems that both a screening diagnosis with REC above 14 to 18%, heterozygotes are lower. So it seems to really be an appropriate test. And we can pretty much relate this free copper with the extra hepatic disease. But even in France nowadays, it is pretty much the diagnostic test that we use it. And this is the test that we should conduct in order to detect it. The REC is currently the most sensitive and biochemical test, yes. Again, the threshold above 18. And if we go into genetics, it's not easy to know it. This is exons, introns, a lot of variability. And we see a lot of mutations that have been reported, over 900 mutations. And some people, you could find a mutation, and then you look in the databases and you say, wow, it's not in the database. Is it pathogenic? Is it not pathogenic? And that's when everything becomes a bit more complicated, because on a daily basis, people keep on discovering them. You don't know if this means that the enzyme is going to work or not. And here, this is the trial from Dr. Espinosa. We did this in a group of patients, and we found 33 different mutations and 4 mutations. The most frequent is 645R. And it seems simple, but I'm going to share with you 6 cases, 6 difficult. Some cases were diagnosed 30 years ago, but diagnostic and screening has improved in the last 30 years. But in every hospital that has a WD, they should review it. Some people, even if they were diagnosed 30 years ago as positive, maybe they don't have it. This is a patient, age 40, 50 years old, both parents deceased, referring hepatic issues. Patient had drunk alcohol in important amounts, but had stopped. They are presented with a level of Parkinson, anxiety with different comorbidities, dyslipidemia, HIV, polymedications. We saw the transaminase, and we have normal echo, but we had urinary copper 69, ceruloplasmin 14, MRI cerebral, no specific changes, and the ophthalmologist detected bilateral KF ring. So the patient had over 4 points if we use this screening. And you say if the total score is over 4, and especially presented with the kyphosphate ring, you should start. And the patient, we saw the transaminase increasing. That was, you do different changes in treatment. We exchanged it with Wefin, with zinc. It just was not okay. So Carmen came to the working group and they said, let's do genetic. And everything was negative. Everything was negative. Everything was negative from a genetic point of view. And I said, well, I need to perform a biopsy. So I did the biopsy.
Yes. Y entonces,
we did this for several years. I kept the patient with the Wilson. Genetic was not clear. The patient was not improving. You had a psychiatric rather than a neurological. And you have the ring that is there. The ophthalmologist kept on detecting this positive KF ring. Elastographies do not show fibrosis. We do not see a disease progression in the liver. And then we see that but we don't. The zinc, it's pretty much using this copper absorption, and then we see that he is adhering to the medication, and blood copper is always between 45 and 50. So the Barcelona group and the ones that do the REC, and I did the REC, and it had 9%. So I find myself with a patient that has an exchangeable copper that it does not correspond to a Wilson's disease, genetic that is negative, all series of comorbidities, but all the other tests really show a Lexis score. So what do you do with this patient? I am still questioning myself, and I don't know what to do.
So we'll see what can we do with the patient in the future. This is the second sort of case, a patient that has had hypertransaminasemia. She's 15 years of age, overweight, with all the etiologically tests negative, with a ceruloplasmin within that range between 10 and 20, with an urinary copper elevated, with no KF ring. And with all these clinical manifestations, we performed a biopsy with a high level of copper in the liver and also a fatty liver as well. So we did the Lipsky calculation, and there was potential 3 points, but not a full case. This is a patient for a long time ago, and many of these patients are all patients. So we started the treatment with DPA, penicillamine. This copper was highly pathologic in the liver, so the urinary copper did not detect that. So we did the DPA, no improvement, and I changed the treatment to zinc. We did the switch to zinc, no improvement. There was a fluctuation and no changes actually between the blood tests and the copper results. The elastography always indicates the absence of fibrosis, and then Carmen came up and we did this gene study. I did a hepatic rebiopsy, because we don't do the copper here. We do that in Barcelona in a site, and the result shows me that the copper level is very low in the liver. I'm not an expert, but it seems that the copper in the liver is bound. And even though you do a biopsy later on, you still find that if we have Wilson's disease, we would need a higher level. But that's not the case. I do the exchangeable copper, and basically it's less than 14. So I decided to abandon the treatment. This is a patient with overweight, and we find the fatty liver in the ultrasound. I've been treating the patient for more than 2 years, and we have this normal copper metabolism, and I've down the exchangeable copper, and that's pretty low. The Leipzig would not go up, but this is a mistake of the intrahepatic copper level. Okay, we have this sort of borderline case, no personal background. So diagnosed with Wilson's disease, with transient hypertransaminemia. Basically, the serum transmina was between 14 and 18. The urinary copper was 128, and the uremia was low as well. No KF ring. They detected lots of copper, and with this result, we have this diagnosis of Wilson's disease. The patient was treated for 12 to 13 years with zinc plus D-penicillamine. He didn't tolerate the zinc, and we interrupted that. The patient went abroad to work and stopped the medication because they didn't have access there. And I met him when he came back from abroad. Basically, the ultrasound is okay, the elastography result is fine, the blood test is okay. And I'm thinking, is this a Wilson's disease patient? And I found that the CP is 19, the copper is 54, but the urine copper at 24 hours, that was high at the onset, and now it was 13. And I thought that there might be a mistake. I didn't do the biopsy. I asked for a genetic study to Carmen. Everything was negative. Exchangeable copper, the result was 6%. So, okay, we have to, the person has to abandon medication, and that's fine. Okay, 4 case, and I think it's the last one, maybe. Okay, overweight patient, hypercholesterolemia, hypertransaminemia, high levels of transaminase since 18 years of age, all tests to exclude any liver diseases. We did that with the rest of the patients. The patient had undergone B hepatitis, and the ceruloplasmine was fluctuating between 17 and 22 milligrams, a fluctuating urinary copper, but was never twice the ULN, no ring, and intrahepatic pathological copper quantification. Fatty liver as well, so the patient scores more than 4 points, Wilson's disease, and we start the treatment. And we administer penicillamine, renal toxicity, then we switch to trientine, doesn't normalize transaminase, and finally we administer zinc. And with the clinical course over 10 years, no improvement in liver tests, fluctuations, therapeutic changes, then I go back to creatine, and there is back and forth in this patient, but it doesn't improve. Carmen does this gene study, negative, and the relative exchange copper, it's 5.2. And then we did a discontinuation of the treatment, and the patient is fine, and the patient did not worsen. I will not tell you all the cases, but I have a total of 6 patients where REC and genetics, we found patients with a lack of response to the treatment, patients also with an atypical neurological presentation, psychiatric patients, negative genetics in one of the cases, in 4s and 2s we haven't been able to do that, or heterozygosis, and the biochemical copper metabolism data are close to normal ranges. The urinary copper is not pathologic, and well, despite us, these results are not conclusive, and they allowed us to abandon the treatment in some patients, but not all. We found these alternative diagnoses that have been fatty liver within a context of obesity or overweight. So I won't tell you what we have to do, because I cannot give you a diagnosis algorithm. I think it depends on each site. Some of them might have access to gene tests. Other sites can have access to exchangeable copper. Other sites only to quantify copper and biopsy. But I think all these techniques have their mistakes and errors, and we've been able to see some of them. But it's pretty clear. Those patients that are very, very clear and you don't make a mistake, that's fine. But this exchangeable copper and the confirmation with the gene test, I think makes you very comfortable that this diagnosis is pretty good. And I think that's it. We need to combine all the different tests, the gene test and the exchangeable copper. They've helped me quite a lot in some of these diagnoses. They were made before 1994, 1996, and the technology probably has advanced, but many people have been diagnosed with this treatment, and I think we need to do a follow-up. Thank you very much.